So good morning everyone. I'm here to present a case of herpes simplex keratitis with anterior uveitis. So introduction. Herpes simplex virus is a common cause of infectious keratitis and anterior uveitis. And herpes simplex keratitis is a recurrent disease that can lead to corneal scarring, vision loss, and increased intraocular pressure due to associated uveitis. This case report describes a patient with recurrent HSV keratitis complicated by anterior uveitis, highlighting the clinical presentation, diagnostic challenges, and therapeutic management. So the patient profile, a 35-year-old female, Pratima, presented to the ophthalmology clinic with a 5-day history of redness, pain, decreased vision in her right eye. She reported photophobia and tearing with a history of previous similar episodes, although less severe, occurring over the past 2 years. She had been diagnosed with herpes simplex keratitis in the past, but was not on any prophylactic antiviral therapy. There was no history of trauma, systemic disease, or any recent illness. So in the right eye, the best corrected visual acuity was 624. Slit lamp examination shows conjunctival injection, dendritic lesions on the cornea, central staining on fluorescein, and mild stromal edema. There was 1+ flare, 2+ cells in the anterior chamber, indicating anterior uveitis component. Intraocular pressure was elevated at 28 millimeters of mercury. Pupil was mildly sluggish, but there was no afferent pupillary defect. Fundus, the posterior segment examination was unremarkable. Left eye, the visual acuity was 6.6, and the anterior segment was normal. So this picture shows the dendritic lesion. The patient was diagnosed with recurrent herpes simplex keratitis with concurrent anterior uveitis and ocular hypertension. The corneal dendritic ulcer with associated uveitis and elevated IOP are the hallmarks of HSV keratouveitis. Immediate treatment was initiated to address the viral keratitis, inflammation, and elevated IOP. So topical antivirals, ganciclovir 0.15% gel 5 times daily for the dendritic keratitis. Oral antiviral therapy, valacyclovir 1000 mg 3 times a day for 10 days. Topical steroids, now they had to be started cautiously due to the epithelial defects. So after 4 to 5 days, the patient was started on prednisolone acetate 1% 4 times. For topical cycloplegic, cyclopentolate 1% twice daily. IOP lowering agent timolol 0.5% twice daily was used. Follow-up, at the 2-week follow-up, the patient showed significant improvement. The dendritic lesions had healed, stromal edema had decreased, the AC inflammation had reduced to trace amounts, and the IOP had dropped to 18 mm Hg with the topical treatment. Oral antiviral was discontinued after 10 days, but the topical steroids and IOP lowering agents were tapered off over the following weeks. At 1 month follow-up, patient's visual acuity was 6.9 in the affected eye. Complete resolution of inflammation and normal IOP, the patient was prescribed low-dose oral valacyclovir 500 mg once daily for long-term prophylaxis to prevent future recurrences. So herpes simplex keratitis is a leading cause of corneal blindness in developed countries. It can present in various forms: keratitis to stromal disease with or without uveitis, recurrent HSV keratitis with anterior uveitis, and as seen in this case, poses a significant risk for corneal scarring, stromal inflammation, and secondary glaucoma. So the management of HSV keratouveitis is complex due to the need to balance antiviral therapy with the cautious use of corticosteroids to control inflammation without exacerbating the viral replication. So this case underscores the importance of early and aggressive management to prevent complications. Antiviral therapy is the cornerstone of treatment, while corticosteroids necessary to control the uveitis. Long-term antiviral prophylaxis is often recommended in recurrent cases, as it is notorious for recurrences that can lead to progressive damage and vision loss. So conclusion, recurrent herpes simplex keratitis with uveitis highlights the diagnostic challenges and therapeutic consideration in managing a viral keratouveitis. Prompt initiation of antiviral and anti-inflammatory treatment along with careful monitoring of IOP led to a successful resolution of the infection and inflammation. Long-term prophylaxis is essential to prevent future recurrences and preserve the patient's vision.
Very nice presentation, Aashna. One thing I want to ask, why did you use the atropine? You used cyclopentolate, and for how long did you use cyclopentolate?
Sir, for 2 weeks. When the patient came at 2 weeks, so the pain and the ciliary spasm, the pain due to ciliary spasm had reduced, so we had stopped it at 2 weeks.
After 2 weeks, did you look for the flare and cells if they were present? Should you have not continued that the cycloplegics?
Yes, sir, but sir, the reaction was minimal. So yes, we should have continued.
Look, if the patient is having inflammation, why didn't you use the cycloplegic till the eye is absolutely quiet? There are no flare and cells in the eye.
Yes.
And secondly, how long did you use your topical steroids? You used prednisolone. Earlier, with the caution, you could have used earlier the weaker steroids, because earlier when the epithelium is in a healing stage, the steroids delay the healing of epithelium. So it may lead to the basically other secondary infections and more, and delays all the healing process.
Sir, after 5 days of topical antiviral therapy, we started the patient on steroid. And after 2 weeks, we started tapering both the steroid and the other drug.
What was the frequency of tapering? Whether it was 5 days, 7 days, 10 days, the top tapering?
Sir, it was started at 4 times. So after 2 weeks, we tapered it at 5 days each.
5 days. You tapered it within a month, basically.
Yes.
You can say.
Yes, sir.
After 5 days, you can say it stopped in 1. I usually prefer to start with the 6 times day and weekly tapering of the dose of the steroid.
Yes, sir.
But there are different. It depends upon how much is the amount of inflammation is there,
Yes, sir.
and how fast it recovers, basically. So it was very nice presentation.
Thank you.